always it is a rhinosinusitis. Okay, it is a rhinosinusitis. Even though it is a chronic granulomatous disease also, have those classifications I have given you about the chronic granulomatous disease of the nose. Even though they are along with the sinuses they are involved, we have given it as a rhinitis and then rhino. That's we'll have a separate discussion about the various conditions of the sinuses. Okay, let us start with the granulomatous diseases. With the last class, one thing I have not, because of the time factor, I couldn't think is, one is vasomotor rhinitis. I have already told you now. What do you mean by vasomotor rhinitis? Anyone? Okay. What is vasomotor rhinitis? Last class I have told you. Because always our nose, nasal secretions are dependent on the autonomic nervous system. Whenever there is an imbalance between the sympathetic and then parasympathetic systems, there will be a nasal discharge, because overactivity of the parasympathetic, overactivity or the decreased sympathetic activity can result in, okay, that balance is lost, and then so which is maintained by median nerve. What is median nerve? What, can anybody tell about the composition of the median nerve? Which will travel along the median canal of the sphenoid bone at the floor of the sphenoid sinus, and then it is all otherwise known as pterygopalatine canal, pterygoids and then palatine. So that is the thing. So in that, what is the treatment for it is, one thing is parasympathetolytic drugs can be given, and also the surgical maneuver is videoneurectomy. Videoneurectomy can be done transnasally, transsphenoidal, and transmaxillary sinus. These are all the various routes where you can go and then ablate the median nerve. You can cut and then cauterize, or you can inject absolute alcohol, and then you can ablate the median nerve. So that is the median, that is regarding the vasomotor rhinitis. And the next is rhinitis medicamentosa. What is rhinitis medicamentosa? That is overuse of nasal decongestants can give rise to rebound phenomenon, and then the patient can have a rebound turbinate, and then there is an engorgement of the sinusoids, and then the patient will have a nasal obstruction. Even after using the locally acting nasal drops, the patient will have nasal obstruction. So means because of the rebound phenomena of the condition, pharmacological overuse of the nasal decongestants can give rise to this, and then the patient can have a nasal obstruction. An examination, you can see whenever there is a nasal obstruction, there is an engorgement is there, over secretion will be there, that the secretions will be there. Sometimes it will be dry also, because they are using the local decongestants. But the patient will have consistently, the patient will have nasal obstruction. Whenever there is a nasal obstruction there, secondarily the patient sinuses will get obstructed, and then the patient will have vacuum headache, and then also can lead to pent-up of secretions and also sinusitis. So for this, the thing is, first of all, the offender should be stopped. What is that offender? Offender is your local decongestants. First of all, stop the local decongestants, and then you have to give only saline drops into the nasal cavity. Okay? Isotonic saline drops, and also one has to give systemic as well as local steroids. This is the treatment for vasomotor rhinitis. So these are the two conditions where you can get a 2 marks questions. One is a vasomotor rhinitis, another is a rhinitis medicamentosa. So this is a treatment for rhinitis, vasomotor rhinitis is it is parasympathetic drugs, or sometimes you can give sympathomimetics also. If they don't work, usually because it has the autonomic imbalance, it is next thing is surgical ablation is video neurectomy, because all the symptomatology and then signs will be all the watery rhinorrhea will be there, and then autonomous control. So suddenly the patient a small trigger of a psychological or any uh, a trivial trauma can induce that rhinitis. This is the because of regarding the rhinitis. Now, let us go into the today's topic is a chronic granulomatous disease of the nose. So, usually all the granulomatous diseases of the nose are a local manifestation of a systemic disease. Usually, there will be a systemic disease will be there, but they manifest in the nose. That is mostly here they simulate neoplasm because they resemble a malignancies. That's why one has to be bear in mind whenever there is a malignancy also one has to bear in mind chronic granulomatous disease as a differential diagnosis. So coming to the classification, it can be a fungal, bacterial, or spirochetal, or unknown. These are all the things which can give rise to chronic granulomatous diseases. Fungal, is anything like aspergillosis or mucormycosis, any superficial mycosis or invasive mycosis. Just a minute. శ్రీనివాస్ గారు క్లాస్లో ఉన్నాను ఏంటి చెప్పండి. అలాగే పంపించండి, నో ప్రాబ్లం. అలాగే అలాగే అలాగే. Okay, so and then there is another thing is rhinosporidosis. Rhinosporidosis is one entity, one disease commonly we see here because most of the coastal areas of the Srikakulam, Jayanagaram, and Odisha, these are the people who usually they will be coming to us. We are seeing a rhinosporidosis. And then bacterial, if you go to the bacterial, there is the rhinoscleroma, lepromatous leprosy, tuberculosis of the nose, and then lupus. Lupus is another form of disease, tuberculosis disease, where is a milder form. Locally, it will manifest. And then syphilis is a spirochetal disorder, which we are seeing, not seeing nowadays. Previously, there used to be syphilis is a very, very, after the invention of penicillin, the incidence of syphilis has come down drastically. And then there is unknown lesions. There is a known as midline granulomas. One is Stewart granuloma and Wegener's granuloma. These are the two types. This is the classification of the chronic granulomatous diseases. Coming to the rhinosporidosis, because the fungal diseases usually they manifest in a different fashion. They may present as a fungal mycetoma or just like a fungal rhinosinusitis, polyposis. So that is being dealt in the chronic rhinosinusitis also. That's why now we are not dealing with the aspergillosis or the mucormycosis. It is an invasive, it is a non-invasive, superficial mycosis or invasive mycosis. So rhinosporidosis is a one condition, is a chronic granulomatous disease caused by a fungal parasite. So it is a fungus or a parasite. There is a dilemma still. So known as Rhinosporidium seaberi or Rhinosporidium kennelii. So the name of the thing is Rhinosporidium seaberi or kennelii. The family is Oplidiaceae, and then order chitidales and phycomycetes other. So because the presence of chitin and the wall of the sporangium of the rhinospiridium, it is a between a plankton and then zoonotic, that is the parasitic. So it can be some say it is a parasite, some say it is a fungus. So it is still a dilemma, mostly seen in all the ages. No age is immune. Mainly, the males are predominantly infected, and then the geographical disturbance is usually in the coastal areas of the tropical countries. India, Sri Lanka, Bangladesh, South America. And in India, it is coming to coastal AP, parts of UP, Orissa, and West Bengal. And also, it is seen in some parts, all the and the West Coast also. But it is rare. Mainly, it is seen in the East Coast. So, Kerala, Tamil Nadu, Andhra Pradesh, Orissa, only very rarely it will involve the North India. So usually that is seen in farmers. So it can be called as an now occupational hazard for a farmer. So those who work in fields, the cow dung or any animal excreta and everything. So those are the people who usually contacting the diseases. So the important prerequisite for any the disease to contact is a trauma, either a trivial trauma in the nose or a surgical trauma. A surgical trauma will further spread the disease whenever there is a trauma by way of nose picking or any inflammation or anything. So any ulceration is there, though this sporangia will get large. So most of it is seen in people who bathe in infected waters. Some say it is a droplet infection also, but the it will involve what is the pathology? Coming to the pathology, it involves the mucosa of the nose, oral cavity, lips, palate, paranasal sinuses, nasopharynx, larynx, trachea, bronchi, lacrimal sac, conjunctiva, and then genitalia and skin, and also can involve into the systemically spread and then can get deposited in liver also. Okay, so these are all the various pathologically it will invade the whole of the body. So mode of infection is and transmission usually not known, but mostly spread is by contact or air, water. So mostly it is a waterborne disease. Bathing in contaminated waters is the main reason. Most of the time, if you take a history, most of the people say so. There will be a history of bathing in a pond or some lakes. So wherever there is a animals, both everything will be clean there. So whenever they do a bathing or swimming for any swimming purpose, they go, then there is every chance of contacting this rhinospiridium. So a culture and animal inoculation was so far not done. So how the spread is not known. Because by history itself, we can say most of the time they will be working in fields or there will be a history of bathing in the contaminated waters. So what is the life cycle? Life cycle of a rhinospiridium. Rhinospiridium, usually it is a, if you know what is a sporangium, what is a spore? Can anybody say what is a sporangium and what is a spore? Hello, Aishwarya? Can you tell me what is the difference between a spore and a sporangium? Yes, sporangium a large thing where the spores are there. Okay, good. So the life cycle, usually spore, it will measure around 6 to 7 microns. It may be a oval or round in color. So the cytoplasm of the spore will be vacuolated, and then there is a membrane, is a chitinous membrane to the spore. So it will increase to the, because it gradually increases whenever it gets lodged in any surface of your raw area, the nasal cavity or anything, anywhere in the respiratory tract, it will go and then gradually it will grow to a size where 50 to 60 micron size. So then the nucleus divides and then cytoplasm becomes granular. When it reaches 100 microns, the cellulose depo, except at the pore, because at the pore it is weak. All around the cellulose deposition will occur. The at the stage of 250 to 300 microns, it will become a sporangium, and then it will be a white, visible, and then which will contain many innumerable number of spores. So this sporangium will have double chitinous envelope with a germinal pore. The spores escape from the sporangium through the germinal pore. The germinal pore is at the level where the cellular deposits are, cellulose deposits are not there. And then there is no chitinous membrane also. Very, very small pore through which the sporangia will dissipate and then disperse out, and then they will spread into the tissue of the nasal cavity, wherever it is there, to the intercellular spaces, and then connective tissue. It will go and then they again start spreading, so increasing their size. So when this type of the multiple spores getting, and then they will enveloped by granulation tissue and then form as a polypoidal reddish, then red or pinkish mass with the white dots, that is the sporangia with them. So they will appear as if like a just leaf like or a polypoid like hanging from the nose with a single small attachment in the nasal cavity. So they spread and then they will grow into the nasal cavity, and then wherever there is a space is there, then go to the appear as a strawberry appearance. The appearance of the thing is, gross appearance of the rhinosporidium is strawberry like, but this is the life cycle. So one has to see this from 6 to 7 microns to what, how it is going growing, and then chitinous layer with a pore, germinal pore, again sporangia, and then again is going to spore. That is the life cycle of the rhinosporidium. So if you see under microscope, you can see the granulation tissue showing multiple sporangia. These are all sporangia with a granulation tissue. This is a sporangium in the high magnification with multiple spores. So the clinical presentation can be divided into a benign or a malignant. Malignant means that is severest form. That it means if it involves the systemic organs, that is the extensively, if there is an extensive rhinosporidiosis involving the systemic involvement is there, then we call it as a malignant, or that is known as, otherwise known as generalized rhinosporidiosis, involvement of the skin, liver, all the bone. These are all the things which can get involved. So benign conditions, majority of the rhinosporidium is nasal. The 16% of the cases only exclusively nasopharyngeal. So mostly nasal and nasal mixed type will be there. 63% will be mixed type, and then involving the ethmoids, and then all the sinuses along with the nose nasopharynx. And then bizarre type, that is another known as bizarre type, is it may involve anything is a conjunctiva or tarsal or cutaneous. Whenever it is known as, if you see these things, we call it as a bizarre type of rhinosporidium. So malignant is generalized rhinosporidiosis, including involvement of skin, liver, and everything. So 78% of cases produce nasal symptoms like nasal obstruction, a blood-stained, that is a serosanguinous nasal discharge, bleeding or frank bleeding, have a protrusion, a fungal mass coming out of the nose. So it is very much highly vascular, strawberry-like, a polypoid or leaf-like, pink to purple in color, attached to septum or lateral wall. Anywhere there is a small attachment will be there. Sometimes extend to the nasopharynx, or it may come into the oropharynx also. Surface of the mass studded with white dots representing the sporangia of the fungus. It will easily bleed on touch. Whenever you, so that's it's one of the differential diagnoses for malignancies of the nerves and paranasal sinuses. So it will be like this: a mass presenting in the nasal cavity with the vestibule. So, but attachment will be somewhere else, either in the nasal lateral of the nose or to the septum of the nose, or it can be a. So, how do you diagnose? So, one thing is a typical appearance is one of the thing, and then history of bathing in all the infected ponds. These are all the various things which we can diagnose, but ultimate diagnosis is only by the biopsy histopathological examination. So whenever you take a biopsy, that will bleed, usually invariably bleed, but you have to pack the nose after taking a biopsy. Under microscope, you can see the sporangia, and then filled with spores, and then there will be some the various stages in the life cycle. Wherever there is a life cycle is there now, all the various stages you can see the various sizes of sporangia, and then various sizes of spores from 6 to 7 microns to 250 to 300 microns. This is the finally we'll diagnose, and then spread. Usually it will go to the from nasal cavity through the nasolacrimal duct. It can go, or it may get deposited in the eye, and then can present through the in the conjunctiva, or it may through the eye drops. That is the tears. It will go into the nasolacrimal duct or get deposited there whenever there is any raw area is there, and then from there it can present as a nasal mass, and then it can go directly and then into pharynx, trachea. So these things which the spores which may dislodge, and then they go in, and then wherever there is a raw area is there, there is every chance of implantation is there. And then lastly, genitals, skin, liver, and spleen. Whenever all these things are involved, we call it as a malignant rhinosporidiosis or generalized rhinosporidiosis. So this is the one type of conjunctival, because when there is conjunctiva is there involved, so the inferior punctum, closing the punctum, and then the patient will be having epiphora. They present to the ophthalmologist. Usually, you see these are the studded with white sporangia, a leaf-like or a polypedal-like thing, which can give rise to conjunctival rhinosporidiosis. So, what is the treatment? So there is a medical treatment is there, but which is not at all useful. So when you don't know whether it's a fungus or a bacterium or a protozoan, so all the things are being tried, and then antifungals tried, but there is no benefit. Usually they used to give dapsone for longer periods, but that also doesn't. The only thing nowadays, dapsone is being reserved for after surgical treatment to prevent any recurrence we are using. But the mainstay of the treatment is only surgical excision from the site of origin. So the excision can be the diathermy, because whenever you are doing, when you excise, that means you are causing another raw area there. So if you produce a heat and everything, or a laser or a cryo, so these are all the various things which to prevent further implantation of the diseases. Still, even after using all these things, the recurrence is the order of the disease, because we see most of the cases recurrence, most of the time they come with recurrence. So now with the advent of the nasal endoscopes, good visualization, and then better surgical clearance, because whenever we see we can see through the endoscope, we can see where from exactly it is coming from. And then at that level, we cauterize. And then after that, we follow regularly. And then we have to give a dapsone post-operatively. And then see recurrent, if there's any recurrence again, you have to subject the person for repeat surgery. Recurrence is very, very common. Next is a bacterial. There is a bacterial infection, rhinoscleroma. It is a chronic progressive granulomatous disease involving the, mainly it is the nose, but it can extend into the pharynx or the larynx, the rhinoscleroma, laryngoscleroma, like that. So whenever it is seen in the pharynx, that is, pharynx also can get sclerosed and then stenosed. So here it is also a chronic granulomatous disease, which is characterized by sclerosis and stenosis of the nasal passages and the nasopharynx. So as I have told, it may extend to the subglottic region or the trachea also, rarely. Going to the history of this thing, because it is otherwise known as Hebra disease, Hebra nose, described by von Hebra in 1871. He is the person who first described the disease. But it is until then Mickledge, he is the person who first described histology. So the cells are being named after him, known as Mickledge cells. Frisch is the person who identified the causative organism. So that way, otherwise known Frisch bacilli in Mickledge cells. Frisch bacilli are seen in Mickledge cells. What are Mickledge cells? Can anybody tell? Pathology, you have finished pathology, no? Can anybody tell what is a Mickledge cell? Mickledge cell macrophages, because which are engulf the parasitics, okay? Good. So these macrophages are vacuolated things, and then they contain the Mickledge cells contain the Frisch bacilli. What is the bacilli caused by? What is the causative organism of rhinoscleroma? Klebsiella rhinoscleromatis. Yes. So it is Klebsiella rhinoscleromatis. Okay. So age is around about 20 to 30 years. Females are more involved than the male. It is distribution in Central Europe and South America. Also in India, mainly North India, some parts of South India, especially in Visakhapatnam district, we see them in mostly from the agency areas. They are coming to us with a disease. Some people will come in the early stage, some people will come in late stage. So always it is a low socioeconomic because of the poor nutrition with a decreased immunity, the patient will have the disease. And then causative organ Klebsiella rhinoscleromatis are otherwise known as Frisch bacilli. So it is a droplet infection. So mode of transmission is droplet or by contamination of the material that is subsequently inhaled through the nose cavity, and then it gets deposited. So whenever the patient is not in a position, good diet and good nutrition, they will have that disease, they will contact the disease. So granular containing Mickledge cells, Russell bodies and lymphocytes. Say plasma cells, that is the macrophages with a Russell bodies. What are Russell bodies? Russell bodies are the plasma cells. Yes. So, and then lead to gradually, this is the stages of disease is there. We'll go next. There is, and then the end stage, they form a dense scar tissue, and then they will occlude the complete nasal cavity. The surrounding area will become very tough and woody nose. That is giving rise to woody nose. Okay, these are the Michel's cells in a high power. You can see the macrophages with a fish bacilli within that, and then this is the plasma cells, the Russell bodies with the inclusions. Plasma cells with inclusions are known as Russell bodies. So that is not a pathognomonic of rhinoscleroma, but pathognomonic of rhinoscleroma is presence of Michel's cells. Okay. So here, these are the Michel's cells which will contain the bacilli. So it is having a three stages. Either one is either catarrhal or atrophic. Either it can be a discharging or it can be atrophic stage, just like other atrophic rhinitis where there will be crusting and then foul smelling discharge and everything, or sometimes just like any rhinorrhea catarrhal stage, initial stage viral rhinitis, the patient can have a discharging nose with a sanguinous, sometimes sanguinous also. Next is a granulomatous stage, forming a granular, then nose and the granules can be seen, and then finally they heal by always all the granulomatous tissue is nothing but a what are granulation tissue? What are granulation tissue? The immature fibroblasts with a vascularity. So then they heal by fibrosis, cicatrization. Okay. And then this is a case where there will be a cicatrization is there, and then granularity. With some discharge also will be seen. At the end, this is the otherwise known as hebranos, or otherwise known as noma. Okay, so there will be a stenosis. There is a completely occluded. The nose is being occluded by complete fibrotic tissue, and then it will be nose will be very just very hard like a wood, and then that's why it is known as woody nose. Okay. Catarrhal or atrophic stage, the patient will have rhinorrhea, a non-specific rhinitis which progressive into purulent fetid rhinorrhea with crusting which can last for weeks or even months. It resembles just atrophic rhinitis. If you don't treat at this stage, it will go into the next stage is a granulomatous. The patient will have nasal obstruction with rhinorrhea. Granulomatous is a progress to chronic stage, is a nodular lesions in the nasal mucosa, mucous membrane, and then nasal vestibular skin. There will be a granulation. If you take a biopsy there, you can typically see the granulation tissue along with the Michel's cells. And then because of the obstruction of the sinuses ostia, the patient will have sinusitis. And then last stage is cicatrix extension to the palate. Then whenever it extends to the palate, there is a palatal movement also will be restricted, then obstruction, and then the patient will have rhinolalia. When there is an obstruction, what is the type of rhinolalia? Then the clasa, yes. Okay. So, and then disease extend to the sinuses, oropharynx, because all the surrounding areas, the disease will extend, and then the scleromatous lesions can go there and then cicatrize in the nasopharynx. The palate may get attached to the posterior pharyngeal to the perseverance reach, and then completely nasopharynx and oropharynx get closed, shut. So that can also happen. Or it can extend to the facial distortion, extending into the anterior nares, go to the face, and then get a facial distortion. Can down to the nasopharynx, oral cavity, larynx, and trachea, and the bronchi also it can extend. extension to the larynx, though the laryngosclerosis. This is also one of the entity where the patient will have going to respiratory embarrassment. Whenever it completely obstructs the larynx, the one has to go for tracheostomy. And then if it goes to the nasopharynx and obstructs the eustachian tube, the patient may go into develop otitis media with effusion or chronic supraotitis media because the nasopharynx, where the eustachian, the pharyngeal part of the eustachian, pharyngeal end of the eustachian opens into the lateral wall of the nasopharynx. So this is the laryngosclerosis, where you see the vocal cords gets stenosed because there is a some psychiatric membrane. So only the posteriorly it is some gap is there. So when it is completely excluding that the geoparadise, the air entry, then the patient will have stridor and then one has to go for, or it can get deposited in the trachea and then tracheal stenosis also can occur. Mostly subglottic stenosis. So always diagnosis by history, where from they are coming, the geographical location, and then clinical examination. On examination, you can see the different stages. So most of the patients they will come to us with either granular stage or psychiatric ulcers. Nobody is coming to in a primary catarrhal or atrophic stage. If they come, we can treat, and then there is a, because it is a bacillary, the bacterial infection, we can give antibiotics and then local emollients. So local treatment with just like any atrophic rhinitis also, you can remove the crust, then you can restore the normal mucosal continuity. And then clinical examination, after that you can take a biopsies and then radiological examination to see whether the patient is having any sinusitis or anything, and then biopsy and then culture from the material. So you can culture the fish bacilli. Treatment. Coming to the treatment, antibiotic therapy is streptomycin, tetracyclines, putrimazole, vibramycin, rifampicin, doxycycline, chloromycin are tried to 4 to 6 weeks because clofazime also given at 100 milligrams BD for 3 months. And then to prevent the cicatrization, we have to give steroids, local as well as systemic steroids. We have to try. So with this early treatment, you can prevent the cicatrization and then sequelae of the rhinoscleroma. So the surgery, the part of the surgery is only whenever it is completely occluded to recanalize the passage, the airways, establish the airway, and then to correct the nasal deformity, just like any deformity of the nose. That's the rhinoplasty surgeries. And then for any canalization of this psychiatric material, one has to use a better thing is laser. Laser, with the laser you can burn out all the psychiatric tissue and then you can put some stent so that it can epithelize and then give rise to a airway. And the next is leprosy. So still the leprosy is one of the conditions, and also tuberculosis. Why we are not seeing? Because tuberculosis always anyway in the body is always secondary to pulmonary tuberculosis. Lupus is another form of tuberculosis where it's a milder form where you can see the ulceration of the mucosa. What is the type of ulcer in the lupus? Hello. What is the type of ulcers? What are the types of lupus? Have you heard of lupus? Apple jelly granules. These are all the various things where you can see a ulceration described with the apple jelly nodules. Okay, and then it is also a tuberculosis. These things have to be usually, because nowadays all the tuberculosis diseases, first of all, they have to be sent to the district tuberculosis center, because the therapy, if you give a therapy, one has to be radical. So otherwise, there's it is mandated now. National Tuberculosis Control Program have mandated each and every diagnosed case of tuberculosis have to be sent to the district tuberculosis center, and then they have to give a thing. Coming to the leprosy, it is the oldest infectious disease of the known to the mankind. So it is also common in tropical diseases, tropical countries, and widely prevalent in India. Srikakulam is one of the thing, and then Tamil Nadu, Orissa. So much of rampant disease is there. And then near Vellore, there is another leprosy center is there. Likewise, there are so many leprosy centers are there. So as per the WHO statistics, there are around 2.2 million cases in the world. Out of these 2.2 million, around 55% of the cases were found in India only. So high prevalence is Tamil Nadu, Orissa, Bihar. These are all the conditions. For every 1,000 people, there are 5 people are infected with leprosy. So you can see, out of these cases, 15 to 20% are children. So you know what is a leprosy caused by Mycobacterium leprae? It is a acid fast bacilli. Nasal involvement is common with the lepromatous type, whereas other types, what are the other types? Lepromatous leprosy are a part of systemic disease. It is a systemic. Nasal involvement is common. Of course, nose is common involved in tuberous leprosy. And then, okay, so in this skin, most of the thing in our nose, and then white patches and everything will be there. Here, usually, even without that, the patient will have a lepromatous type of leprosy with a nasal involvement with a. So the granulomatous nodules, there is a necrosis, ulceration, and fibrosis. Here also, there will be a nodular appearance. There is a necrotic tissue will be there. The granular tissue necrose, and then they ulcerate. So as the nerve endings are being, the patient will never have anything. So the ulcerations will increase, and then they will heal by fibrosis. If it happens in the nose, what will happen? So there is a histology. If you see the infiltration of lymphocytes, plasma cells, epithelials, and then blood vessels, there is a glands and nerves. So nuclei and vacuoles, large giant cells are contained. This is a giant cell. Presence of giant cell is around the lepra bacilli is the typical of leprosy. So the spread can take through the lymphatics also, along with the contiguity can go to the lymphatics. Most is the earliest involvement site of lepromatous type of leprosy. Involvement of the anterior part of the septum. So here, leprosy, the cartilaginous part mainly commonly involves, get involves, and the inferior turbinate and ala of the nose, and then can result in cicatrization and then deformity. A saddle nose deformity can occur with this lepromatous type of leprosy. So initially, how it will present is a nasal discharge and a swollen, the congested nasal mucosa. So later on, there will be ulceration, crusting will be there, and then nodular lesions to the septum, ulceration, perforation of the septum, and then sensation of the nasal skin and mucosa is lost. So what will happen? The sequelae of the leprosy is it may lead to atrophic the atrophy of the nasal complete mucosa, depression of the bridge of the nose with collapse, deformity of the alar region of the alar cartilages, alar retraction, then destruction of the anterior nasal spine with a columnar retraction, and then collapse of the nasal bridge, and then the rarely, very rarely, the stenosis can take place. So always the diagnosis is by clinical examination, and then nasal mucosa scrapings, and then staining by the Gill-Nielsen staining, and then biopsy from the nodules of the ulcerations. So here it is a treatment, it is a systemic disease. So one has to treat the. So these are the dapsone, rifampicin, clofazimine. So here the district leprosy control people will come, and then they are the people usually they will be treating. But these are the drugs, dapsone, rifampicin, and clofazimine are being used. And then surgical part is only a plastic reconstruction of the deformed part after complete treatment of the disease for at least 2 to 3 years. After complete treatment, one has to go for reconstructive surgery. Coming to midline granulomas, which is a disease of unknown etiology, causing extensive destruction of the disease, the tissue in the midline, that is mostly around the nose and then mid of the face, mid face. So there will be complete destruction and then deformity, and then the patient can have the very, very ugly appearance because of the destruction, mutilation. Okay, what are the types? Stewart type of granuloma and Wegener's. There are two types are there. Stewart granuloma or Wegener's granuloma. Stewart granuloma is unknown etiology. Now it is believed to be a malignant lymphoma. Just like any Burkitt's lymphoma, this is also a Burkitt lymphoma. Also, there will be destruction will be there. Like that, here also there will be complete destruction of the midline structures, the nose and the palate and the health round. Here also, histopathological examination of the biopsy shows plasma cells, lymphocytes, and lymphoreticular cells. Swelling of the first, initially the patient will have swelling of the nose, the vestibule are just like vestibulitis, vestibules will be involved, and then nasal septum is formed, and then go to ulceration, and with the progressive destruction of the cartilage and bone, completely midline mutilation, and then so systemic spread is very, very rare. So it is a locally contained disease where only thing is surgical debridement and then only prosthetic cover for the deformity. Because here, beyond plastic repair, they will be mutilated and then destructed. So here, because it is thought to be a lymphoma, radiotherapy is one of the treatment. Coming to the Wegener's granuloma, is a systemic involvement of upper respiratory tract infection, lungs, kidneys, besides locally ulcerative. So, besides locally ulcerative disease can use upper respiratory tract or lower respiratory lungs and kidneys commonly gets involved. So, etiology is also unknown. Both sexes are equally affected. Common age of occurrence is 40 to 50 years with the fifth decade. Here, the pathology is giant cell necrotic granuloma with vasculitis, chronic granulomatous vasculitis, and multinucleated cells will be there. So the Wegener is because of is a German Nazi. That's why recently this name is being replaced by chronic necrotizing granulomatous vasculitis. This disease is further named as a chronic necrotizing granulomatous vasculitis. The most common effects are the nose are turbinates, nasal bones, the nasal septum. And then along the symptoms, there is nasal obstruction, nasal discharge, pain in the nasal sinuses, bleeding from the nose, change in the voice because it may spread to the larynx, and also ear discharge spreading into the ears through the eustachian tubes, and then hearing loss. These conditions can be accompanied by system seasonal fever, malaise, and then night sweats, weight loss, and migratory arthralgia. These are all the associated symptomatology with the venous granules. So here, patient will have rhinorrhea, crusting and granulations of the, with the necrosis of the nose and the nasal septum, destruction of the septum, going up with the orbit, palate, and the oropharynx. And then there will be pulmonary involvement is there. The patient will have cough, okay, blood-stained sputum, hemoptysis. So, and then X-ray chest shows multiple cavities in the X-rays. And then kidney involvement, if there is any hematuria, one has to suspect kidney involvement. So on physical examination, you can see a reddish thickened septal mucosa, a septal perforation, or involvement of the nasal cartilage and the bone, which can result in extensive deformity such as saddling of the nose, presence of hearing loss because related to the recurrent serous suppurative or suppurative otitis media. So diagnosis is only by clinical features and biopsy. Treatment is by steroids and then chemotherapy. That is cyclophosphamide, azathioprine. These are the tried, but this is a very, very debilitating disorder where the treatment is not satisfactory. Thank you. Amma, this is